just a full disclosure here, I am not a pediatrician, and then hopefully have a great discussion after that. So let's just launch into it. And I'm always happy to take questions. Amala, if you want me to stop at any time, feel free to jump in, okay? So the first thing I want to do is recognition. I was trying to find the right word for this. It has been a terrible year for all of us. And as I talk through this, if it elicits emotions that are stressful or something similar, I understand. I feel all the same things, especially as we are now right around a year of dealing with this in our area. This has impacted individuals, this has impacted families, communities, friends, loved ones. And I just want to, again, acknowledge and recognize that it's been horrible. And if you feel horrible, it is normal. I hope that as we move forward and think about vaccinations and reopening things and getting our kids back to sort of maybe some normal existences and interactions, we'll be able to start the healing process as we go through that. So with that recognition, we are in the midst of a worldwide pandemic. This is a snapshot from the Johns Hopkins guide that I think many of us used last spring. It's still a very effective tool where you can see the distribution of COVID-19 cases across the planet. And you can see here in the United States on the left-hand side, deep amount of red there, indicating a large number of infections. But you can see basically no place has been spared. You got to remember that the ability to detect infections means that you have access to testing as well. So where there's lower rates of testing, there's going to be fewer cases detected as well. And that's a whole separate important issue. But as it stands, as of this afternoon, when I took a snapshot of this, we're approaching 115 million cases in the world. And you can see the United States is currently leading at the country level in absolute numbers. But there's been a number of other countries that have been impacted similarly when you start breaking it down by population size. And you have the list there. And Amal, I'm happy to give you these slides right after this, and you can share them with whoever would like to see them. When we look at what's going on in the United States, this is again a snapshot from earlier today in the CDC numbers. What this is showing us is a graphic of the number of cases per day, excuse me, since last March. And so you can see on the left-hand side is just the number of cases. Along the bottom are dates. The blue lines are the absolute number, and the red line is the average over the prior 14 days. And so what you can see here is that spring surge, which here in Seattle we experienced very, very early and was really the first community to be impacted. But very quickly after, we're seeing in pretty much every other state in the United States. We had a lot of mitigation measures, which I'll talk about across the U.S. We had a shared summer surge, which I'll come back to. We can see that nationally we came back down with a number of mitigation measures, but never got back to that same low-level plateau that we had in the late spring, early summer. And then the very, very large winter surge that we are all coming out of now. These notches that you see represent holidays. So this is kind of the November holidays and then the late December holidays where people got tested at high levels prior to going to and coming back from family events, but then didn't get tested right around the holidays. And so that's a fully expected notch, those two notches you see there. And then you can see this very, happy decrease over the last 6 weeks. But I will point out that at that end there, that tail is a plateauing and maybe even a slight increase in cases. And again, I'll come back to this shortly. This is bringing it to Washington State. You can see the distribution and the waves are very, very similar here. That early spring surge across the state, the summer surge that included and really hit Eastern Washington, especially hard. You remember the reports last summer from Yakima and similar that kind of hit East Washington, then reflected back into Western Washington. Same thing here with that plateau over the summer phase, never quite got as low as the late spring phase. And then this very, very large number of cases over the winter time, again, with those notches representing holiday decreases in testing. And similar to the United States, sort of a flattening or a plateau of the number of cases more recently. I will also point out, just in terms of dates, going back, I mentioned that recognition at the very early part of this and thinking about what we've all gone through. We had this incredibly compressed series of events early on. February 29th was the first described death in the United States that we learned about. And it was within a matter of days that our lives just got turned around. On March, some schools started closing that first week of March. On March 2nd in Seattle, a civil emergency was declared by Mayor Durkin. Within a couple of weeks, all Washington State schools were closed. Restaurants and bars closed shortly after, followed by a stay-at-home order. And then, in April 6th, all Washington schools were closed for the rest of the year, which, is an important part of tonight's discussion. But again, reflecting this huge amount of activity in a compressed time frame very early in that spring surge. And when we think about what happened in the summer and we think about what happened in the winter, our lives obviously continue to be very challenged, excuse me, but so much happened back in that spring surge that sort of set the stage for the subsequent activities for the rest of the year. Bringing it into King County, it's very similar in Snohomish and Pierce counties. That again, this is our spring surge here. Because so many of those cases in the spring were focused in King County, we see a pretty high peak here in that early part of the spring of 2020. That was pretty similar for us in King County to the summer surge. And then this very large surge again with the November holidays and the December holidays represented by those notches. And then decrease in cases. I'll say just importantly behind all this is a big decrease in testing. People just haven't been testing as much. And why that isn't 100% clear. Part of the winter testing was a lot of people getting tested for family gatherings. And without those holidays, there's been, I think, less of an incentive for people with minimal symptoms to get tested. But you can see that even with that, the number of cases has gone down. But similar to the United States, similar to Washington State, you see here in King County that the number of cases and the average over the past week has been pretty stable. I'll just point out one little subtlety to this graph is that this gray bar on the far right means that not all the data has been reported. So, at the very least, this is likely to continue to be flat or maybe even tilt up a little. So when we think about these data, I really think about the trends over time and not individual data points as being really important. But good news, as of March 2nd, which I think was yesterday, only 128 cases, which is down from, the 700, 800 that we were seeing per day in King County. I'm sorry, this is a little bit small to see, but I wanted just to point out that there are other data that we also rely upon. It's not just the number of cases per day, but we also track very closely the number of people who end up in the hospital. We know that as case counts go up, that eventually leads to people who need care in emergency departments and ultimately potentially in inside hospitals in what are called acute care floors, sort of routine medical care in the hospital, and critical care units or ICUs where people are severely ill. And you can see that we had a huge spike in the spring. And that was because we saw so many outbreaks in skilled nursing facilities or nursing homes that impacted older adults. And that was an incredible tragedy because many of those older adults died as a result of these infections. Less of an impact during the summer, but then a very large impact on our healthcare facilities with the winter surge that it fortunately again has come down nicely most recently. But I will point out that we seem to be hitting a period of stability now with the number of new admissions per day. Lower, but still not as low as we want it to go. And then finally, on the right in the gray is the number of deaths. And again, we saw a huge number of deaths in the spring because of the populations being impacted. Fewer in the winter surge, but still very substantial. And right now, the data is about a week out, but on average, about 3 deaths due to COVID-19 in King County per day that are directly related to COVID-19. So kind of giving you a snapshot of where we've been, what's sort of driven some of these things, and where we are right now. I want to be very specific to call out the proportions of infections in different populations within King County, and this is true for Washington State, this is true for the United States. And this is critical way to think about this particular pandemic, but really all infectious diseases. As an infectious disease doctor, it is very clear to me and to people who practice in my area that infectious diseases prey upon people and inequities that are inherent in our systems. So these are not surprising when we have things like structural racism that segregates people's access to care, access to things like testing and information. And we see this play out over the last year. When we look at King County, and what I'm showing you here in the gray bars is the percent of how people self-identify in terms of race or ethnicity in King County. So the gray bar on the top is people identify as white, are about 60% of the King County population. People identify as Black, around 6.5%, Hispanic, Latinx at around 10%, Asian, 17.2%, Native Hawaiian Pacific Islander at 0.8%, American Indian Alaska Native at 0.6%, other at 6.2%. So those are the proportions of people in the county. But what we're looking at, the percent of cases in the blue bars, is a gross disproportionality, where most cases, if you look at, you'd expect by population, if everything was equitable, you'd see about 60% of cases would be in people identify as white, yet it's only about 40% of cases. And conversely, in people identify as Black, Hispanic, Latinx, or Native Hawaiian Pacific Islander, you see that there's a disproportionate increase in the number of people who are infected in those populations that vastly outstrips the proportion within our King County population. So just to call out, for instance, Black population is 6.4%, yet represent about 12% of cases. Hispanic, about 10% of cases, residents in King County, yet almost 24% of cases. And I think really important that the Native Hawaiian Pacific Islander population, although smaller proportionally in King County, you can just look at this distribution, 0.8% of population, yet almost 3% of cases, triple the number that you'd see in any of these other populations, which is really, really awful. This is just a way to look at it in a slightly different way. This is just age-adjusted rates per 100,000. And so you can see where there's a reference group here, it's people identify as white and blue. And then you look at significantly higher rates than reference group. And you can see where you look across, pretty much every other ethnic or racial group has a higher than the white population rate of disease, with some, particularly, as I called out, the Native Hawaiian Pacific Islander population being hit extremely hard. And it's really important to look at those smaller populations that you see on this graphic. It seems like, oh, it's not such a big deal. But when you start looking at normalizing that for the number of people, it's really quite devastating. Shifting over to where we are as a state, I think everyone who follows this in the media recognizes that Puget Sound region, so that's Pierce, King, and Snohomish counties, are all in the Puget Sound region for the roadmap to recovery. This is the governor's plan to sort of reopen society. This was started about 6 weeks ago or so, maybe 7 weeks. We were all put into phase one in these geographic areas. The last time we did this was by county, and this is the new plan. And so we basically reset it, put everyone at phase one, and you had to hit these 4 metrics. Your case rate had to go down by about 10%. Your trend in admissions to hospitals had to go down by 10%. Your ICU capacity, so the number of people requiring critical care, had to be less than 90%. And your percent positivity had to be less than 10%. If you hit all 4 of those, then you can move from phase 1 to phase 2. You can see that 3 out of 4 seems to be okay as well, because basically all of Washington State is now in phase 2. And that comes with specific parameters around who can be in a restaurant, how many people can be in a salon or in a gym or similar. But I will point out, in some parts of Washington State, we are still seeing significant percent positivity. 10% to 14% of all tests being positive is still a lot. And, what I like to point out when I look at graphics like this and talk about it is that what we're really talking about is a balance between public health, masking, distancing, staying home when you're ill, and all these things, and political pressure. And, ultimately, this is a decision made by politicians with public health input, not a decision made by public health leaders by themselves. So the last thing I'm going to say is, Dr. Ibrahim is going to talk about vaccination. In this, I'll just say that I am wildly hopeful around the issue of vaccination. These are incredible tools that are really going to be the answer to getting us out of this pandemic and all the restrictions that we've been experiencing. At the same time, I go back and forth between wild optimism around the incredible potential of these vaccines and their very real concern around these variants you may have heard about. They have a lot of complex names. Our preference is not to use the site of origin to sort of identify, but it is the kind of the easiest shorthand. People have heard about these variants, the one that was described in the United Kingdom, the one that's described in the Republic of South Africa, and the one that's described in Brazil. And as of today, all three of these variants, which are associated with increased transmission or escape from immunity, at least natural immunity, are present in the United States. The last one, the P1 from Brazil, was described in Minnesota in a publication today. So we have the UK variant that's also known as the B117 in Washington State. That's probably the most numerous one that we have here. It's hard to know how much we have, and I can certainly answer questions about that later. But there is significant concern because this B117 variant, the one described in the United Kingdom, is about 40 to 60% more transmissible. So if the other variants, if one person was infected, they infected on average, around 1.7 other people. This new variant means that if you have that new variant, on average, you infect between 2 and 3 more people. And that doesn't seem like a lot on a one-to-one basis, but when you start doing sort of the trees with this person and then the next 2 people and the next 2 people and the next 2 people, those numbers get very large very fast. So we have this challenge where we don't have enough vaccination yet. The vast majority of people in Washington State are not immune. They've not been infected with COVID-19, which means that they are susceptible to COVID-19 right now, these infections. And we have more opening in society and variants that are circulating that are more transmissible. So again, I kind of go back and forth between wild optimism around the potential of these vaccines and the significant challenge that the variants pose for us. So with that, I'm going to stop. I'm going to turn it over to Anisa. Thank you.
Thank you, John. Let me start by sharing my screen. All right. So I am going to talk a little bit about the COVID-19 vaccine development, safety, some vaccine myths, and then kind of end up with talking about the Washington State vaccine distribution and the phases. Just like John said, please feel free to stop me or we can take questions at the end. My caveat is that unlike Dr. Lynch, I am not an infectious disease expert or an infectious disease physician, but I talk about vaccine questions, vaccine hesitancy with the community a lot, and it's one of my passions. And I hope to kind of share the same information that I share with many community members with you guys tonight. So vaccine development, I think it's one of the questions that scientists and doctors and everyone kind of talk about, and we talk about it quite easily, saying, oh, these are the phases of vaccine development. That might seem straightforward to us, and we're hearing it a lot in the news as well. But I thought that it's really important to kind of know what are the phases of vaccine development, and how do we know if a vaccine is efficacious, is it safe, is it effective? Because those are the two things, and do the benefits outweigh the risks? Those are the important things that we continually think about when we're talking about vaccinations. What we're talking about is prevention of disease. So this is a typical vaccine development timeline, not a timeline, but kind of a vaccine development progression. So the preclinical phase, it's, this is what the scientists around the world were talking about last March, early March, is thinking about how will the vaccine work. This is when scientists are thinking about what type of vaccine are we going to create, which type is going to be the most effective, how will the vaccine work. This is when people will talk about the type of vaccine. I'll get to it in a little bit, but is it going to be a vector vaccine? Is it going to be an mRNA vaccine? Things that we've been hearing a lot about, especially in the news. That's the preclinical phase. So the second phase 1, and then phase 2A and B. So phase 1 really is when the vaccine, once created, is really tested on a small group of people. So we're talking about 20 to 80 people. That is looking at the safety and the immune response of the vaccine. Is it safe? Are we going to see any significant side effects? And what kind of immune response is this vaccine going to generate? Phase 2A really looks at determining the dosing and the safety, further information about the safety. And the dosing is important, and it's things that we've been hearing about a lot. How many doses do we need in order to get X immunity? How many doses? Even within a vaccine, what dose needs to be administered for the vaccine to be as effective as it can be, but also safe without any adverse side effects. And then the next phase is if we see that the vaccine is safe, that we haven't seen any significant side effects in these small groups of people, is the vaccine effective? Now, phase 3 are these much bigger clinical trials that are looking at what are the disease rates. And this is when, we start to talk about people getting the vaccine versus the placebo, and having that kind of rigorous trial that looks at what are the disease rates between the folks that have gotten the vaccine versus the folks that have not gotten the vaccine. And that's when this efficacy data starts to come out. And we've been hearing a lot about, Pfizer is this is how effective the Pfizer vaccine is at preventing COVID-19 disease. And this is how effective the Moderna vaccine is. This is how effective the Johnson & Johnson vaccine is. That phase 3 is really what gets us those efficacy trials, and how well does it do to protect you once you've received the vaccine. After those phases is when the vaccine will go to regulatory approval. Now, because we are in the middle of a pandemic, we've been hearing a lot about the FDA and whether, which vaccines are going to get FDA approval. And currently we have a few vaccines, so we'll talk about that, do have FDA approval under emergency use. And that does not mean that these vaccines are any less safe than other vaccines. It just means that, we're in a pandemic. We are saying that it is effective against emergency use, and it will continue to be regulated and monitored for a long time, as are, all vaccines. And then phase 4, just because, it is deemed safe and effective, does not mean that the information gathering ends. And this is, what really, that rigorous information gathering is important even after it gets approved for the general public. So, to date, there's still a lot of data being collected, and, millions of people have now gotten the vaccine, and there is data being collected. And is there anything else that we're going to find out, from these bigger clinical trials to now it is in the real world, collecting data to say, how continued efficacy, continued side effects are. Is there something that we didn't expect? And for the most part, we have really seen that the benefits far outweigh the risks with the vaccines that we have currently. And I'll get into just kind of discussing, there's some top level information about the vaccines that we have available to us now. But in and of itself, every step of this vaccine development timeline was followed for all of the vaccines that were developed for COVID-19. And despite it happening on a faster scale, and I think that's one of the things that many community members have asked me, this is really fast, and it is true, but just because it was fast, we have a global, there were many barriers removed for companies, for scientists, and we had the entire world thinking about this problem and trying to find a solution. But that does not mean that any of these rigorous steps were skipped. All of these steps were followed. So COVID-19 vaccine. As of this week, there are now 3 COVID-19 vaccines that are FDA approved for emergency use. So that is the Pfizer and BioNTech vaccine, the Moderna vaccine, and then most recently the Johnson & Johnson vaccine. So how they compare, let's first compare the Pfizer and the Moderna vaccinations, because both of these are what we call mRNA vaccines. What mRNA vaccines are first, mRNA vaccines have been studied for a long time. This is not something that was just discovered specifically for the COVID-19 vaccine, but an mRNA is essentially a molecule that tells our body to make proteins. And specifically, it tells our body to recognize the spike protein that is very specific to the coronavirus, SARS-CoV-2. right? And essentially the way that I think about the way these vaccines work is they are essentially showing our immune system, they're holding up a wanted poster, right? They are showing the immune system, this is what COVID-19 looks like. This is the protein in which you can recognize it. And once the entire body kind of memorizes that and says, okay, this, we are going to have a reaction, we are going to remember, then that information, that mRNA gets degraded, that wanted poster goes away because everyone knows what COVID-19, your body and your cells now are able to recognize it. That information is degraded, and what you are left with is your body being able to prevent an infection because it recognizes this vaccine. So it's a wanted poster essentially. And then that mRNA vaccine is essentially degraded. So, many have asked, I'll kind of go through a myth versus fact slide later, but that's not something that just continues to stick around. Okay, but your body remembers it given our immune system. The Pfizer vaccine is currently 2 doses given 21 days apart, compared to the Moderna, that's 2 doses given 28 days apart. The Pfizer vaccine is 95% effective, and the Moderna vaccine is 94.1% effective. And then age group, the Pfizer vaccine is approved for ages 16 and up, and the Moderna vaccine is approved for 18 and up. Neither of these vaccines were initially studied in children, and that's why we are not giving them to children right now. But there are robust studies ongoing right now looking at how doing those same trials, looking at, can we give the vaccines to younger kids? Is it safe? Is it effective? Ensuring that we go through all of those steps so that we can roll it out to children as well. But currently it is 16 for the Pfizer vaccine and 18 and up for the Moderna vaccine. Now, Johnson & Johnson is the newest one that that was currently FDA approved, and it's continuing to go through some essentially some additional bodies, independent bodies are continuing to review it for safety and efficacy. And I think that this vaccine, it is, when you're just comparing numbers, it's a little bit harder to compare because when it was developed, the type of vaccine it is. And currently what I do want to say is that any vaccine in your arm is the best vaccine because it is giving you protection. But I just wanted to go through and just highlight some of the differences. The first one is that Johnson & Johnson is a vector vaccine. So it essentially has, unlike our mRNA, it essentially has material that shows your body what the COVID-19 virus looks like, that is inside of an adenovirus vector. Again, it's harmless, the adenovirus vector. It cannot cause disease, and adenovirus is a virus that causes the common cold. And that is what essentially causes, that is what your this vaccine uses and tells your body to make a harmless proteins to prevent against COVID-19 infection. Okay? Its overall efficacy is 72% with 85% efficacy against severe disease, which is really, really important. It's also effective. We have data saying that it's effective against the UK and South African variants. I'm sorry that I don't have the scientific names on there. As Dr. Lynch has pointed out, but I think I agree that it is important to not just call them that, but call the variants what they are. And then it is currently, again, approved for mostly adults as well. Now, looking at safety, and this is something that, I answer a lot of questions about in the community, and it's really important to make informed decisions about anything health-wise, but specifically, it's really important to ensure that you are able to get the information that you need in order to protect yourself, and specifically when it applies to the COVID-19 vaccine. So the safety data from vaccines have been independently reviewed. So they've been reviewed by the companies. We've seen the safety data, and there have been independent bodies that have reviewed the vaccine and showed that they are safe and that they are effective. So far, none of the vaccine trials, including the ongoing data collection, have shown reported any significant safety concerns. And like I said, there's over 2 million people who have reported symptoms on the CDC site after they've received a vaccine, and many have only really reported these side effects that are essentially expected because it's an immune system response. And those side effects are pain and swelling at the injection site. Many people, up to 70% of people, do have pain and swelling at the injection site. Most people have pain, and a small portion has swelling. Fevers, muscle aches, fatigue, and headaches. Almost all of these symptoms last around 24 to 36 hours, and everyone reports feeling back to normal within that time frame. And then I just wanted to go a little bit through just kind of myths and facts. And we don't have to spend too much time on this, but these are the common things that have come up for me time and time again. If that will come up in the community, this slide is adapted from Children's Health. First is that the COVID-19 vaccine alters DNA, and the one that that question's mostly been associated with knowing that the Pfizer and Moderna are mRNA vaccine, and that the fact is that mRNA doesn't actually enter the nucleus and does not change anyone's DNA, and it's actually degraded after it does what it's supposed to do, essentially holding up that wanted poster, getting your body to recognize. Second is, as we discussed, because these vaccines have beautiful efficacy, and that because they were made in such record time that it isn't safe. But the reality is that there's been thorough safety standards have been met, and every single one of it's gone through every single thing that every other vaccine has gone through, and we're continuing to gather data. There's been questions about, can I get COVID-19 from the vaccine? And the vaccine cannot give you the virus because there's no virus for it to give you. There's no COVID-19 inside of the vaccine, in the vaccine, so you cannot get disease or illness from the vaccine. Another myth is that I've had COVID-19, so I don't need the vaccine. And what we know is that natural immunity does wane. And when it wanes, you are at risk for reinfection, and the vaccines can prevent reinfection. Other things include, there are some studies that show, food and allergy, immunocompromised people, breastfeeding or pregnant women can't get the vaccine. And there is a consensus amongst experts that all of these people can get the vaccine. There are there's a lot of data reported to the CDC of breastfeeding and pregnant women who are getting the vaccine and have done fine. And then the last one is there's no need for masks and social distancing after the vaccine. And I'm sure Dr. Lynch has also heard this at all. And the reality is we are still in the middle of the pandemic, and we have to take care of each other as a community. And until we have the data and the numbers to support loosening some of these things, it is really important that we stay vigilant so that we can get through this and that we continue masking and socially distancing, even if we have the vaccines ourselves, because the rest of the community has not been vaccinated yet. So talking about Washington's COVID-19 phases, so currently we are in this phase 1B, tier 1, and the most exciting update is that as of last night, Governor Inslee has added childcare workers and school personnel and staff effective immediately to this phase. So these phases are progressive, and what we're hoping is that we vaccinate the people who are most at risk, and the people who are at highest, most at risk both through exposure or are most at risk if they were to get infected with COVID-19. And I understand it's very frustrating when there's a vaccine and everyone wants it, but I think that there is a thoughtful approach, and I am always challenging everyone to center equity when we are rolling out these vaccines. But as of right now, Governor Inslee included school personnel and childcare workers effective immediately. They were going to be in the next tier anyway, but I'm glad that they are, as with many people going back to school or having school activities, I'm glad that they are added effective immediately. And then throughout the spring and summer, we're going to continue to go through these phases. I know President Biden is continuing to work with all of the companies to ensure that every adult can get a vaccine as soon as possible, but it takes time. And we're, hoping that the vaccine, that we're able to develop enough vaccine to go around. As of right now, if you think you are eligible, the Washington State Department of Health has a phase finder. And when I think about these things, I think about the communities in which I care for, that there is a digital divide, there is a language barrier, so there's a lot of barriers to accessing sites like this. But right now, this is the site that we have, and there's a lot of community organizations that are going to help support people who need to need help going through this website, as well as the clinics at Harborview are and I'm sure other hospitals are reaching out to communities, ensuring that this interface or a language barrier isn't preventing folks from using Phase Finder. So you essentially go through this, and it tells you if you're eligible or not. It presents your visit certificate if you are. if you are eligible, then there are tons of vaccination sites listed, but there has, as many people have seen, it's kind of hard finding a place and a place that has an appointment and has a vaccine, which is why many communities are working to do pop-up vaccination sites. So communities are not having to go outside of their travel. They don't have to be, they don't have the barriers of transportation or language barriers, or, the discomfort of leaving your own community to go and get a vaccine. So people are continuing to work on this, but there is a site that can kind of help locate a vaccine. And then the last thing, I think this is really my heart's work, is when communities band together to launch and, stand hand in hand with our colleagues and our community members and our elders to say, we are going to eliminate as many barriers as we can to ensure that our communities are protected. In Rainier Valley, community really banded together to provide COVID-19 pop-up vaccine clinics. And this picture is from the Brighton Apartments, which is a senior living complex, and the Somali Health Board, Adela Station Pharmacy, folks from the Dariel program at Harborview really banded together and said, here's how we're going to eliminate all the barriers. Let's get the community vaccinated. And there was no hesitancy. There was the community saying, you have interpreters, you've made this easy, you've eliminated barriers, we are there, we want to get vaccinated. And it really brings me joy going to every single one of these vaccine pop-up sites and interacting with people and having them really celebrate finally being protected and seeing a light at the end of the tunnel. All right, that's the end of my slideshow, so I will stop sharing my screen and I'll pass it back to Ahmed.
Thank you so much. Amel, you might still be muted too.
Thank you. Thank you, Dr. Ibrahim and Dr. Lynch. We're going to move on to the question and answer session. If this is a time for you to speak up if you have questions, or to type in the chat.
Awesome. Andrea, maybe you and I can kind of call out these questions for our doctors. So I'm seeing one here. Oh, it looks like Dr. Lynch has already answered that.
He's all over it, yeah.
I've been trying to answer them as we go.
Okay, fantastic. Thank you. The question was, are there any confirmed cases of anyone that has gotten the vaccination and then gotten infected with the variant? Dr. Lynch, do you mind just answering that again out loud?
Yeah, definitely. So, so I don't know the entire setup in the United States or in Washington State, but I know that locally, we have had one person that I know of, who was infected after being fully vaccinated. What I mean by fully vaccinated, it means after 2 weeks after the second vaccine for the Moderna and Pfizer. Those are what's been available so far. So someone's fully vaccinated 2 weeks out from their second vaccine. We know that someone was tested positive. What I don't know is whether we have any information on whether it's a variant or not. So I just want to be one thing, and it's really important, and I'm glad you asked me to say this out loud, is that all the vaccines work against all the variants. And most importantly, against the B117 or the UK strain that Anisa referenced. That's probably the most numerous here in Washington State. Still small numbers, we think, but is the most numerous. This, the Moderna, the Pfizer, and the Johnson & Johnson vaccine all work against that variant. The real concern with that variant is its impact on unvaccinated people. And so that's a really important thing. And although, you're seeing a lot in the media about the ability for the 1351, that's the one from South Africa, being able to bypass, immunity. What we've really seen is probably a slightly decreased effectiveness, particularly in the Johnson & Johnson vaccines effect against that variant, but still really, really good. So instead of being, 80%, it was closer to 70% or, 85 to 70%. But also importantly, in South Africa, in Brazil, and in the United States, where that Johnson & Johnson vaccine was tested, and in Republic of South Africa, where the 1351 strain was circulating, and this is true for the other vaccines too, 0 deaths. In the Johnson & Johnson vaccine, there were 7 deaths in the people who got the placebo, 0 in the vaccinated arm. And that's all 3 countries. And Anisa mentioned a really huge impact on severe COVID-19. That definition was quite broad. It included people who just had trouble breathing, people who had high heart rates, or some other, what I would say on the in-hospital side, more minor symptoms, but what they classify as severe. The decrease in hospitalization in the vaccinated arm was also 100%. So no one got hospitalized either. So really, really profound. I should say no one. In the folks over 70, there was a few folks, but in the under 70, it was 0. I mean, really amazing. And that's where the 1351 was circulating. So maybe a little bit less effective, but still very, very potent.
Thank you very much.
Thank you. I did not know any of that, so I really appreciate hearing from experts on it. There was a question here about ideas, and I'm prioritizing this as a mom of a 4- and 6-year-old as well, who would like to have their grandparents around. So there's a question in here from Bryce. Hi, Bryce. Thanks for asking. Any idea when the current vaccine testing for children is scheduled to be completed, so we can determine when our kids can be vaccinated?
Anisa, do you know the answer to that? I don't know when. I know that the studies for the J&J just started in February, and I do not know when the completions for the others are, but Anisa may know.
I don't know exactly when the completions are. I know that they had been working on doing kind of like going down the age group. Initially, they started with adolescents that were just slightly younger than 16 to 18, and then going down. So we're hoping within the next couple of months, but they have not told us exactly when. I think, the other thing with kids is that overall kids have done better with the disease. However, it's never a chance. It's never it's not a sigh of relief, because kids don't live in their own little bubbles by themselves. They live with adults, they live with grandparents, they have teachers, etc. So that's that they are being careful, ensuring that they go through the same rigorous processes, and that they're able to roll this out to younger kids as well. So again, we're hoping within the next couple of months, and I know that Moderna had gotten a little bit of a head start over Johnson & Johnson, but we just don't know exactly when the end dates will be.
Thank you, Dr. Ibrahim. The next question here is the UK, or I think South Africa, probably SA, COVID-19 popular or common in Washington State?
Yeah, so I have to say is it okay, Anisa, if I answer this one? This one, I'm going to give you a little, it's a challenging question. So the United States, and this includes Washington State, we don't do a good job of what's called genetic surveillance. We don't actually test lots and lots of the viruses out there for this. So the virus that causes COVID-19 is called SARS-CoV-2. And we don't actually test a lot of the sequences, or we do a lot of sequencing, but we don't look at them. And that's true across the United States. Now, the UW Clinical Virology Lab, which does a large amount of testing in Washington State, is now sequencing about 200 to 300. And I don't know when it's coming out, but very, very soon, the Washington State Department of Health Lab, which is located in Shoreline, will also be ramping up its capability to do hundreds of sequences. So that's where you actually look at every sequence, and you can determine whether it's this variant or that variant or so forth. And so our ability to get a good sense of that is going to get better. But you got to remember, we're only going to be testing a few hundred of the thousands of positive tests that we see every day. So it's a sample. With that, to answer the question directly, is we in Washington State, the one that's numerically more common is the one that from the UK. That's the B117, which again has been linked to increased transmission, but the vaccines that we have works very well against. The one from South Africa, the 1351, we do have that, but at much smaller numbers here in Washington State. And we have none of the P1, which is the one from Brazil here, that although it has been described now in Minnesota. What I would say when we think about this is that these mutants, these variants, are everywhere. They all have been here. They're all over the place. It's a question of how hard you look to find them. And as it stands right now, we don't see the B.1.1.7 taking over and displacing all the variants here, but we're still early in all of that. And we know what's happened in other parts of the world where this has definitely occurred.
Thank you, Dr. Lynch. This is my son, Michael, everyone. He's so curious about why there's so many doctors on the call.
Hey, Michael.
We have a question in here from the chat. I'm going to phrase it more kind of how I've been reading about it, are under-resourced populations and countries and the impact of lack of access to the vaccine, et cetera, from those populations in our broader world community, what impact we think that will have on countries that do have more access to healthcare.
I have an opinion, Anisa, but you're welcome to go first.
Yeah, thank you. Thanks. I mean, I think that this is one of the things that, this is a global pandemic, and we have to think about these efforts globally. This is not the time to just give vaccines to countries that have more resources or more money, because just like we saw this vaccine, it became an epidemic to a pandemic like that, and it spread everywhere. So I think when we're thinking about the impact, I think it depends on several things. How much of our population is vaccinated, and are we equitably dividing up vaccines so that every population is getting it? Because we're not going to beat this pandemic if we only focus on giving vaccines to high resource countries, because people travel, things, and it's a pandemic, and this is how it's getting from one place to another. So I really do believe that we have to, it is the duty of high resource countries and the world in general to ensure that these vaccines are being equitably given to all populations and not just high resource ones.
Yeah, I agree with everything Anisa said. Infectious diseases know no borders. They will move across the planet. And the biggest impact on low vaccination rates in poorer countries will be on the citizens in those countries. It's been very interesting in terms of the way this is rolled out in many parts of sub-Saharan Africa, aside from South Africa, the way it's rolled out in South Asia, for instance, in India, where the huge numbers, like we haven't seen uncontrolled spread to the level that we've seen in the United States. It's definitely having a big impact. I work in Kenya in those areas, but not nearly in the ways that was initially predicted. At the same time, that doesn't mean that we shouldn't be as active as a global community in providing access to vaccine universally to everyone. But I'll point out that the greater risk to us, the United States, is not other countries. It is our own country, and particularly states in our country that are, I don't even know what the right word is, but are completely going off in the wrong direction around acting as upstanding members of the community in preventing transmission of COVID-19. There is far greater risk in people coming to Washington State from places like Florida, in the future Missouri, Texas, Nebraska, and the Dakotas than there is from coming from Kenya, India, Korea, Thailand, you name the place. And I think we need to figure out ways to get to, moderate the rates that are going to be happening in those, we're going to see in those, it's virtually guaranteed, but also to deal with another pandemic we have or epidemic we have in the United States of vaccine hesitancy, which is a very, Anisa can speak to this certainly as an expert, but is a heterogeneous thing, ranging from, in my perspective, parents who are honestly concerned about the safety of their child, to people who don't want to be told what to do, to people who are honestly preying upon, people's lack of access to information and ultimately leading to killing people and keeping people sick. And we need different answers for each of those populations. I'm sure if you want to follow up on the vaccine part, Anisa, but it's really important.
Yeah, no, I agree with what you said. I think you covered it well.
Thank you both. I think this is the next unanswered question, which is, probably Dr. Ibrahim is our vaccine expert. What is the latest on what portion of the US population has to be vaccinated to reach herd immunity? And maybe even explaining that term herd immunity, I would love to like understand.
Herd immunity. Yeah. So I will say, and John, you can correct me if I'm wrong. I think when the great Dr. Fauci was predicting it, I think we were looking at probably around 85% vaccinated, 80 to 85%. In order to get herd immunity. So the way that I think about and describe herd immunity is infections can go from person to person if an individual is not immune. So it can go from infecting you to infecting another person. Now, herd immunity is achieved when enough people are essentially protected against the virus, that virus doesn't have anywhere to go. It can't go from one person to another, because if 80% of the population or 85% of the population is vaccinated and therefore protected against COVID, then we have reached an immunity where there's not significant transmission between of the virus, of the infection, because it has nowhere to go. Everyone is protected. And that small portion, and generally this works the best if that small portion are people who can't get the vaccine because they're immunocompromised, which we even see most immunocompromised people can get it, or have another medical reason to why they cannot get it, and that actually helps protect the rest of the people. I think a great example of this is something like polio, right? Like their polio was rampant, and then everyone was vaccinated, and polio had nowhere to go because everyone was essentially protected, right? And there's herd immunity. But we've seen time and time again with things like the MMR vaccine and measles, it waits on a little dip in, either vaccine hesitancy or not as many people getting vaccinated. And the moment that happens, then, that infection can start infecting people again, which, I don't mean to compare measles or COVID and the COVID infection. What I'm saying is if enough people are vaccinated, then we essentially beat the virus in the sense that it has no one to infect. And I think the last kind of estimates that I saw were around 85%. I don't know if you've heard anything different, John.
Yeah, I think it's a lot of unknowns.
Yeah.
It depends upon lots of other things like, prevalence in the population. One thing, I personally like this term population immunity. Like, how do we use this tool of vaccination, basically immunization, decreased risk for getting infected with COVID-19 and then being able to transmit it to someone else. And you can just imagine that the vaccine decreases the risk of getting very sick. And we're now learning that it also decreases the risk of getting what's called asymptomatic carriage, being infected without being sick and potentially transmitting it to someone else. And so what we're learning now is, potentially between 60 and maybe 90% decrease in that asymptomatic carriage issue, which means you won't give it to someone else. So that risk goes way, way down, even if you're asymptomatically infected. And what that means is that the vaccine prevents me from getting sick if I'm vaccinated, but it prevents those around me from getting infected. And you got to always remember that there are many people in our society for a variety of diseases who get vaccinated and it doesn't work as well, or they can't get vaccinated for a variety of reasons. And this is true for lots of other vaccines. And what they're relying upon is that sort of interruption of transmission and sort of cocooning around them that keeps them safe. With SARS-CoV-2, what we're looking at is basically you're creating kind of like mini walls throughout society that prevents that network transmission of SARS-CoV-2 through people. And by doing that, you basically by immunizing individuals at a certain number, whether it's 75% or 80%, what you're really looking at is immunizing the population. And that's going to knock off transmission because the virus needs people to get to who don't have an immune response.
Thank you both. Next question here around the grandparents question. Is it safe for kids to hang out with their grandparents who are vaccinated? Can the grandparents carry and infect the infection and infect the kids?
I can jump on this one, Anisa, because I just have a little inside intel. So Friday, the CDC will be releasing guidance on what people who are vaccinated can do, both in the community and within healthcare settings. So I think that's going to be really, really helpful. And I think it's going to go through scenarios like the one you just described. I'll just give a quick snippet on my perspective, my understanding of this is that what we're going to see is a biologically reasonable, and I think now increasingly data supported perspective that say two people who live alone, who are fully vaccinated, right, and live in separate households, they can get together and have dinner together without a mask. That is safe. Say both of those people have partners who are also fully vaccinated. All four of those adults could get together. And where things get a little more challenging is what happens if one of those couples has a child at home who's not vaccinated? What's the chance of that interaction of fully vaccinated adults lead to transmission? It is very, very, very low, right? So for one of those vaccinated people to have asymptomatic carriage and then give that virus to someone else who's vaccinated, that risk biologically, and I think by the evidence, is extremely low. So could those four people gather someplace else and be safe and then return to their household with unvaccinated kids? Yes, that seems very reasonable. And I think you're going to see the CDC guidance on that on Friday. Now, the part, though, to your question is, can you bring a vaccinated person together with an unvaccinated person? And although the risk of asymptomatic infection remains very low, it's still there. And so when I think about grandparents who are vaccinated and little kids who are unvaccinated, I am still in support, and I look to Anisa's perspective on this: masks, a little bit of distance, until we can get those kids vaccinated and safe and sound, or we get much better information around asymptomatic carriage and transmission. I think biologically it makes sense, but we don't want to give wide-ranging public health recommendations until we have good evidence. Anisa, does that make sense to you?
Yeah, that makes sense to me. I still say that until we get more data in, we really want to be careful, especially when it comes to because we don't have the data, and we want to keep the children protected when we know that they can't be vaccinated right now. And just like Dr. Lynch said, we really want to be careful when it comes to making wide-ranging public health, recommendations when we are still waiting on more data to roll in.
Thank you all. This is one, I think we missed this one. I apologize if I missed it, but as we're looking to bring some students back into our building and other schools are reopening, the question is, how often should family members take COVID tests when our kids go back to school?
So, John can also give me his opinion on this, but I have generally have been saying that people should be getting COVID tests if they are symptomatic or if they have known to have a COVID exposure. Now, it's very hard to say, just get tested on a routine basis, because we're just, we want to make sure when people are getting tested and then we're able to use that information. And I don't want to lead to kind of this mindset of, if we go back to school, then everyone has to get tested every week, because I'm not sure that's a good use of resources if people are not symptomatic. But I'd love to hear John's opinion.
Oh, yeah, sure. I'm sorry. I'm typing and listening at the same time. So
no worries.
Answering some of those questions in the comments. Yeah, so I agree entirely with what Anisa said. So the CDC now has guidance. I think they call it a dynamic model for evaluation, and Dan and others may have looked at this, around sort of figuring out the role of different components of preventing COVID transmission within facilities. The first thing is, when we think about opening up, it has to do with the prevalence, how much COVID is out there, and some other things. The thing that I always like to emphasize with testing is it's expensive. It takes time. We want equitable, allocation of resources, and we want, tools that can be useful for all schools to maximize how many kids can get back safely. And underneath all that is that we know for sure, and this is a very important public health concept that people should really take home, is that testing doesn't really play a role in preventing infection. What prevents infections is keeping people home when they're sick, ventilation within facilities, right? Hand hygiene, masking, distancing. Those are the things that prevent transmission, because you could test someone every week and they can still be infectious, you know, a day or 2 or 3 later between those testing periods. Now, we know that using what are all those tools they're called non-pharmaceutical interventions, these NPIs, because they're not pills or vaccines, right? They're just things we do. You use those, keep things very strict. People still transmit. And probably the best example of this is the National Football League, the NFL. They test like everyone every single day, and they still had transmissions. You couldn't test more than they tested. Now, they were able to keep control because they had good buy-in to masking and distancing and all that sort of stuff. But even with every single day, gold standard testing, they still had transmission events. So testing, you know, can play a role, definitely, in what Anisa is saying. You know, exposures, illness, really, really important. But they are, I would argue, not a significant in part of a safety program. In terms, when you compare that to things like ventilation, distancing, masking, and so forth. But that's my opinion.
Thank you both. Being the experts in this, it's so awesome to hear from you. There is a question here. I'm not that familiar with it, but I imagine since you are this is your life's work around, have you read the VAERS reports? I'm not that familiar, but you might be. Would love to hear kind of a response there.
Yeah, so the VAERS report is the Vaccine Adverse Event Reporting System. And so what it is, it's been in place for a long time. And it's historically basically it's meant, you know, anytime you see a problem with after following a vaccination, it's just a report. It's historically been a pretty passive system. It requires people to actively do it. So if you give a vaccine to someone and they develop a fever, you're supposed to report it. If they develop something more serious, you're supposed to report it. And it's really taken on a bigger role now, right? Because we, as Anisa very nicely said, we went through every single stage of the scientific, regulatory, and safety framework for all of these vaccines. Every single step, nothing was skipped. It just happened quickly. We just moved through it faster than we've ever moved through these before, but everything was done. And what we have the opportunity to do now is to capture the data in a massive global, well, in the United States for VAERS, you know, national level, ability to capture all this as we're vaccinating millions and millions of people all at once. And so there's actually several reporting tools right now around vaccination and adverse events, but the VAERS one is a national reporting tool. And I think it's, going to be really, really good. One of the nice things you can also do now when you get vaccinated, and this should happen at the time you get vaccinated, you get a card that you can actually go and report your anything you have. It'll say, okay, it's day 2. Have you had any fever? Have you had, all these things? And then it tells you, have you had your second vaccine? Have you had any of these things? And so I think we're going to learn a lot, and we have learned a lot, and we've been able to dispel a lot of deep concerns that people have reported. You may have seen, there was actually a thing in New York Times today about, I forget which one is the Moderna or Pfizer. And you may have seen this. They get this kind of red patch on your arm about 7 days later. And what we've learned very quickly is that no big deal, not dangerous, not a concern. It goes away. It's expected. It's normal, and it's fine.
Thank you both. We are actually, I realized we're past our time about 10 minutes, but I think we're all pretty engrossed with that. So I'm wondering if maybe each of you just have some closing thoughts for our community around where we're going next and vaccinations, and certainly around schools as well, because that's, what our little community here is, and we're, and so, yeah, thank you.
Yeah. So, I mean, I just like John, I'm really hopeful for the vaccine and the vaccination efforts. I'm in the community almost every week at pop-up sites, really answering whatever questions, ensuring that there's equitable access and really just giving people information so that they are able to digest what we mean by, vaccine, safe and effective, et cetera. That being said, I do want to reiterate that this is not a time to let up and kind of walk back all of the hard work that we've put in with socially distancing, with masking, with ensuring that we're keeping our community members safe. And it is really a community approach to everything. I am, a pediatrician at heart, and I think about children every single day. And I know how hard this year has been on, I have 2 school-age kids of my own. If I have not said it before, I want to say a million times, teachers are amazing and phenomenal, and you guys have an incredibly hard job, and you do so incredibly well. And I know that, kids are itching to get back to school. And I think that we will be able to do this in a safe manner, safe for both of our educators and our kids. But, we still need to we need to be data driven. We need to ensure that data and scientific data is really leading all of the efforts that we're doing, and it's centering that. And we also need to ensure that everything that we're doing is centering equity. So even if we are allowing, kids to go back to school, which kids need it the most, which kids would benefit from in-person instruction, and how do we phase that in safely? So, I do want to end with hope, because I think hope has really gotten us through this entire incredibly difficult year that has brought forth some really scary times and lots of emotions as we have adjusted. Children are resilient, and that's why I love working with them. And why I love seeing them in clinic every day. And I do look forward to them being able to go back to school in a phased, safe, and effective manner. And I do think that can be done. It's just going to require a lot of vigilance and a lot of, checking in to make sure that scientific data is driving our decisions.
That was awesome, Anisa. I echo everything you just said. I would like to, if I have a second, Dan, I just want to comment. Respond to one last question there about 1,000 deaths following this vaccine, the VAERS database. And this is a really important point to bring up, so thank you for bringing it up. The issue is when you vaccinate 10,000 people, right, in anything, or you study anything, intervention, 10,000 people, we're humans. Some of those people are going to die. They're going to die from heart attacks. They're going to die from strokes. They're going to die from getting hit by a car. That same thing happens in vaccine trials. So if you vaccinate 10,000 people, some of those people are going to have a heart attack, maybe even this next day or the day after or several weeks later. Same thing with strokes and all the other things that happen to humans that lead to dying. And while those are unfortunate, it's really important to recognize those have nothing to do with the vaccine. And this is why when we do these studies on vaccines, we have a vaccine arm where people get vaccinated, and we have a placebo arm. And what they look at is the death rates in both of those. And if you look at death rates from things like stroke or things like heart attacks, they're the same. And actually in the vaccine arms, they're lower. What's called all-cause mortality is lower in the vaccine arms. And that's probably because SARS-CoV-2 maybe causes strokes, and maybe it has something to do with heart attacks and some other things, or makes it a little bit worse. And so even though you see deaths after vaccination, those deaths are the normally occurring ones that human populations have. And it's what's really amazing in the vaccines. And I would say it's very unexpected that in all 3 of the vaccine trials, no one died of COVID. No one, the hospitalization rates were extremely low. That is remarkable, way better than almost all the other vaccines we have. So again, yes, people die after vaccination, but it's not because of vaccinations, because unfortunately humans die. It's the human condition. So now hopefully I answered that question. If I'm not clear, I'm always happy to come back to it. I am so grateful to teachers and learning communities. I have 2 kids, sort of preteen, 11, 12, going on 26, and a 14-year-old. I'm so excited to see them back into school. And I'm so grateful for what teachers bring to their lives and to our lives. I am wildly optimistic about these vaccines. These, as I said, are incredibly powerful, and we really need to get them out to every community member, everybody, as soon as possible. And we're really balancing this issue of these variants and access, which is really right now is a production issue. I love that Anisa just demonstrated the incredible public-private partnerships that are going on, the role of community health boards and other similar community boards to get these things out, because that's the way it's going to happen. And yeah, I think that's where I'll probably stop. Yeah, I had another thought, but I can't remember what it was. I get kind of enthusiastic and very excited about these vaccine stuff, but we have, oh, I know what it was. Someone said, should we just not go forward with schooling? And I think that the next, 4 to 6 to 8 weeks is going to tell us a lot. And I do think there's a way, if we really take this seriously, masking, distancing, ventilation, all of these tools to get kids back into some sort of in-person learning environment. It's not going to look like it did in 2019, but I think it's a step in the right direction. There's lots of ways to do it, whether it's hybrid, whether it's staggered, whether it's distanced. When I say distance, physically distanced in the space to make this happen safely. But that, again, it relies upon so many things, and I really defer to experts like Anisa and your school leaders, who I'm sure have been thinking very, very, very hard about this 24/7 for a very long time. Over.
Thank you, Dr. Lynch. Thank you, Dr. Anisa, Dr. Lynch, so much for all of the great information that you gave to our current families, future families, and community members. We really appreciate you taking some time out of your evening. Thank you to our families for attending. I'm hoping that you guys walked away with valuable information. We're gonna share the information that both doctors presented. I put on the chat link how you can connect with us if you have some questions, and I'm encouraging all of you guys to follow us on social media. Have a good evening. Thanks again.